Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. All right, but welcome everybody to today's program, Understanding Cancer Myths and Questions, featuring Dr. Szabo and Amanda Jones. If this is your first time joining a Cancer Support Community Atlanta program, we welcome you. We invite you to participate in any of the programs you see here. We have a lot of great in-person, virtual programs that are all available to you at no cost. I want to highlight we have some great support groups that meet virtually, and one that also meets in person. So if you're interested in that, really fun nutrition and cooking demonstrations that take place monthly. And then of course, education programs like these and stress reduction classes. We have yoga, Tai Chi, a lot out there. So please take advantage of these resources. Don't let this be the last time you attend a program. So to learn more, you can visit our website right there, cscatlanta.org. You can also visit us on YouTube, on Facebook, and not on here, but we also have an Instagram. So check out all the fun happenings on any of our social media outlets. Give us a follow, a like, find us there. All right, and without further ado, I'm going to stop my share. And I'm excited to welcome Amanda Jones with Oncology Navigation with Northside Hospital Cancer Institute. Amanda Jones is an oncology certified nurse with 19 years experience, 18 of those years exclusively in oncology care. She's currently the coordinator for the Oncology Navigation program at Northside Hospital Cancer Institute and will be moderating today's program. So Amanda, we are so happy to have you, and I'll pass it off to you to get things started.
Okay, great. Thank you, Katie. Thanks everybody for joining us today. It is my pleasure to introduce Dr. Steven Szabo. He has over 30 years of experience and he has seen the evolving impact of advanced treatments in oncology. Dr. Szabo is a medical oncologist with Georgia Cancer Specialists and he practices at their Alpharetta and Johns Creek locations. And it is my pleasure to turn the program over to him.
Thank you very much for inviting me to talk. As Amanda said, I'm Steve Szabo, a medical oncologist, and have practiced in a number of different locations and in different healthcare systems. So I've gotten to see oncology in multiple different ways, and it's always really wonderful when I get to speak to the community about different aspects of cancer. I know we always do disclosures. I don't have any disclosures with regards to pharmaceutical companies, but I do have some disclosures. This is actually my first Zoom talk in terms of giving a lecture. So it's a little different for me. Usually when I give a talk, I'm in a room and I get to walk around and have a conversational style. So I'm trapped in this chair. So that'll be a little different for me. And then the other thing is, it's not going to be on one topic. It's going to be on multiple different topics. When this talk was proposed to me, it was proposed as myths, cancer myths, and although it's an okay title, oftentimes myths means that we're passing judgment, and the things I'm talking about can be somewhat, people have different views on them, but there is no judgment in my talk. But I thought they were interesting things to talk about. And so there are things that the patient, when I am in the room with the patient, they ask me these questions, or sometimes they're shy to ask me these questions, but I know they want to ask me these questions. So we're going to talk about the COVID vaccine. We're going to talk about sugar. We're going to talk about diet. We're going to talk about things that I get asked and sometimes don't get asked, but wish I was asked. So I'm going to start off with the COVID vaccine. I'm often asked, what do I think about the COVID vaccine? Does the COVID vaccine cause cancer? Is this something I should be worried about? And for each thing I'll talk about, I've done, each topic could be a topic unto themselves. But I'll try to kind of encapsulate. So the COVID vaccine, which we all know about, we all have strong views about. Does it cause cancer? So it actually does not cause cancer. Why would people think it might cause cancer? What were some of the things that people were concerned about? Well, the name itself, it's an mRNA vaccine, and basically what you're doing is you're injecting genetic material into somebody. It gets taken up by cells to produce a protein that you want to produce so that the body can produce an immune response to that protein and protect you against something. With regards to COVID, we injected you with RNA. It got taken up in the cells in your arm. The RNA produced something called a spike protein. The spike protein was released into the bloodstream. It produced antibodies, and hopefully it produced an immune response that would protect you against the COVID virus. Interestingly enough, the mRNA technology was not initially designed for that. It was actually designed to treat cancer, because there's a whole body of study using mRNA vaccines to try to treat cancer, to stimulate your immune system to kill off cancer. So that was where the genesis of the concern came, was that we were injecting RNA in you. Turns out, just so you know, RNA does not last very long in the body for good reasons. The body wants to rid itself of RNA in the bloodstream very rapidly because it doesn't want to cause mischief in the body. So RNA is a very unstable molecule. And the magic of the vaccine itself was that they could even make a stable RNA to get into a cell. So that was kind of what the concern was. Does it cause cancer? And so there were some initial studies that were concerning. There was a study in Italy that looked at people who got the vaccine between 2020 and 2022, and they compared it to 2017 and 2019. And initially, when they analyzed the data, there was an increased incidence of cancer in that group. But what they found out is that there's this thing called the catch-up phenomena. During 2020 to 2022, we were not really screening for cancer. Our healthcare system was disrupted. People were not getting colonoscopies. They weren't going to the doctor regularly. And so if you looked at that group, all of a sudden you saw this big, rather large blip in stage 4 or more advanced cancers. And they're like, oh my God, we gave people this vaccine and there was more cancers. It turns out that people just weren't able to get health care in a normal sense. And so what you saw was this catch-up phenomenon. And so then when you correct for disruptions in healthcare and disruptions in screening and disruptions for not going to the doctor, and you start looking at other studies, that same Italian study did not show an increase in risk of cancer. And so it looked at 300,000 people. This Italian study looked at 300,000 people retrospectively, and they did not see, when they reanalyzed the data, they did not see this increased risk. They also looked at 8.4 million vaccinated people in South Korea retrospectively, and they looked at 6.2 million people, and it was a rather large JAMA study. And so they did not see this initial increase that they were worried about. So at this point, there is no evidence that there is an increased risk of cancer with the COVID vaccine, which is very reassuring. And for the studies that they did see, they was called a catch-up phenomenon. They were able to correct for it. But what about the corollary? If it doesn't cause cancer, and as far as we know, it does not cause cancer, fortunately, can it actually cure cancer? And that's actually, there was an ASCO study in 2025 looking at 150 people with non-small cell lung cancer and head and neck cancer who had recently got the COVID vaccine, but they were also given immune checkpoint inhibitors. So immune checkpoint inhibitors are antibodies that block the interaction of our immune system with cancer cells. So just to backtrack a little bit, People often think that when they get cancer, their immune system is impaired, that somehow they have an unhealthy immune system. That actually is not true. The vast majority of people who get cancer are not immunosuppressed and do not have a diminished immune system. What happens is that as the cancer evolves over time, they develop proteins on their surfaces that interact with receptors on the immune cells, that when the interaction occurs, it signals to the immune system that the cancer is no longer there. It's a way for the cancer to be stealthy. And so what we have are immune checkpoint inhibitors. They block this interaction so that the immune system can see the cancer, recruit other immune cells, and kill off the cancer. And it's been actually one of the most significant developments in the management of cancer. Where lung cancer was a disease that was measured in months of survival if it was advanced and non-surgical, is now measured in years. And the same with kidney cancer, head and neck cancer. And as we get better and better at manipulating our immune system, we're only going to get better about it. So there was this abstract, as I said, they looked at people with advanced head and neck cancer and advanced non-small cell lung cancer who got immune checkpoint inhibitors, drugs that you've probably seen advertised, Keytruda, pembrolizumab, nivolumab. And they noticed that there was a doubling of their survival when they had gotten the COVID vaccine and proximity to their starting of their treatments. And it wasn't because they didn't get COVID or anything like that. It seemed to have a oncologic effect. And what they think happens with the COVID vaccine is that because we are stimulating your immune system, we're stimulating it in such a way that we're stimulating cells that can identify cancer cells and kill them off. So now they're going to do a study, not retrospectively looking backwards, but prospectively, where they're going to start giving patients with lung cancer, they're going to give them the COVID vaccine in proximity to the immune checkpoint inhibitor and see if they can amp up the activity of it. So I think that's very exciting use of a vaccine, and I think it's exciting use of this mRNA technology. So to the best of our knowledge, the COVID vaccine does not cause cancer, but it may actually have activity in terms of treating cancer. So I thought that was kind of an interesting thing about the COVID vaccine. Another topic that I often get asked is, does sugar cause cancer? And when I'm talking about sugar, I'm talking about sucrose, glucose, fructose, table sugar. And it is actually an interesting question. And although what I would say is that sugar in and of itself is not carcinogenic, it's an energy source for cells. And although cancer cells do require sugar, they don't require it in a different way than normal cells. Their mechanism for metabolizing sugar is not any different. Sugar indirectly does increase the risk of cancer. And I did want to talk to you about that because I think it's important to bring it up. So when a patient asks me, does sugar cause cancer? Sugar directly does not cause cancer, but there are indirect effects from sugar that I do think can increase the risk of sugar. So things that are more obvious, obesity clearly increases the risk of cancer. Why does it increase the risk of cancer? Because it causes increase in insulin production, hyperinsulinemia. You get insulin resistance, so you're producing more insulin. And insulin is a growth factor. It promotes growth of cells. And so there can be off-target actions of excess insulin that can be carcinogenic. It causes chronic inflammation. obesity does, and just sugar in itself does. And also, sugar in repeated doses actually alters the gut microbiome, and that causes inflammation and it causes alterations in your colon. And so, when they've looked at studies, in fact, there was a very large study in France looking at a cohort study of looking at people who consume sugar just in the general population. They looked at about 102,000 people, and they looked at their sugar consumption. And those who were actually, what they said was having more than 6 tablespoons of sugar a day, they had a 17% increased risk of breast and prostate cancer. So it was interesting that if you're a high sugar user, you can increase your risk of cancer. And in this study, they were looking mostly at breast and prostate cancer. But there are other studies looking at colon cancer. And as we all know, that the risk of colon cancer has gone up in our younger patients. So they changed the screening for colon cancer from 50 down to 45 because we're seeing younger colon cancer. And what they found out was with some other large studies that if you drank greater than 2 sugary beverages a day, you doubled your risk of colon cancer. And if you drank 12 ounces of soda per day, of sugary soda per day, it also could increase your risk of colon cancer. There are some actually mouse models looking at the use of sugary soda, that these mice are predisposed to colon cancer and they could really significantly increase their risk giving them a sugary beverage a day. So although I will say that sugar directly does not cause cancer, increased use of sugar does increase the risk of cancer. In particular, drinking sugary drinks, especially when you're starting at a younger age, will increase your risk of colon cancer. And so I think if you have younger children or young adults, we should encourage them to try to minimize their use of these sugary drinks. There are these, high energy drinks that I think younger people do consume that could be detrimental going forward. So that is something to think about. So does sugar cause cancer? It increases the risk of cancer through obesity, through changing your microbiome in your gut, and increasing inflammation. So the next thing I want to touch base on was soy. This is a question I get asked by a lot of women who have breast cancer. So soy are like tofu. They're isoflavones, and and they're phytoestrogens. So they look a little bit like estrogen. They're not exactly an analog to estrogen, but they act as what we call SERMs, and they modulate the estrogen receptor, but not like estrogen itself. So there are SERMs that we use, selective estrogen receptor modulators. The ones that we use to treat breast cancer are tamoxifen, and another one is raloxifene. And tamoxifen, which is used to treat breast cancer, can actually be used to prevent breast cancer. And raloxifene is another drug which was used to treat osteoporosis, but also can prevent breast cancer. These phytoestrogens or soy-specific isoflavones can actually, believe it or not, decrease the risk of developing breast cancer. And the reason why it was always somewhat controversial, because early on there was a thought because they were phytoestrogens, they would actually increase the risk of breast cancer. But that actually turns out not to be the true. They can actually reduce the risk of breast cancer. So they looked at Asian populations, in particular Asian women who have a long history in their diet of eating soy products like tofu and whatnot. And they found actually in that population the use of 3 servings of soy-based products a day reduced the risk of breast cancer by 50%. So that was actually very interesting. And actually, interestingly enough, when you look at Western populations, because soy is not as big a part of our diet, we don't see as big a reduction in breast cancer when we do look at soy intake, but there still is a reduction in breast cancer for those populations, Western populations that do use soy. So what I would say is that soy does not increase breast cancer risk, so one shouldn't be worried about it. It doesn't actually even increase estradiol levels, but it clearly does show a reduction in the risk of developing breast cancer. I did look at whether it reduced the risk of prostate cancer in men because in the past, we actually used high doses of estrogen to treat prostate cancer. And there was actually a large study just published in the use of giving men large doses of estrogen to treat advanced prostate cancer. And it actually does work, high doses of estrogen to treat prostate cancer. But in this case, when you look at the studies, soy really has no effect on reducing the risk of prostate cancer or really doing anything to the development of prostate cancer. So soy is a very good preventative agent for breast cancer. And there was a study that looked at breast cancer survivors who took about greater than 10 milligrams of soy a day, and it actually seemed to reduce their risk of recurrence of breast cancer. So that's an interesting food supplement that you can take with regards to breast cancer. Another topic that I often get asked, and as often in the news, is alcohol and cancer. And it's a little bit controversial because different societies have different views of alcohol. So if you look at the cardiology societies, they actually will tell you moderate alcohol use is okay. And it actually may be okay with regards to cardiovascular risk. But with regards to cancer, there really is no amount of alcohol that is good with regards to cancer. And this is not to say that you should not drink alcohol. It's very much a personal choice. And, some people like to have a glass of wine with their meal. Some people like to have a beer or whatever. We all have to decide what our own risk. We have to make our own risk assessment for what we do in life. But with regards to alcohol, even one drink of alcohol a day, one alcohol drink a day, will increase the risk of women with will increase your risk of breast cancer. And the risk is about on the order of about 5 to 10% of daily alcohol use. So we generally recommend not daily alcohol use if you want to reduce your risk of breast cancer. And this is in particular estrogen receptor mediated breast cancers and postmenopausal breast cancers. This is not young women and breast cancer, premenopausal women and breast cancer. This is an increased risk for postmenopausal women in breast cancer, and generally women, to reduce the risk of women who can have estrogen receptor positive breast cancers. Alcohol seems to affect the liver, and when it affects the liver, it raises the estrogen level. The other thing that alcohol does is it gets converted into acetaldehyde, and that's the carcinogen that increases the risk of cancer in general. Acetaldehyde disrupts DNA synthesis. 2 drinks a day will increase the risk of colon cancer, and greater than 3 drinks a day will increase the risk of liver cancer. The liver cancer risk has more to do with the development of cirrhosis. So greater than 3 drinks a day will increase your risk of developing cirrhosis of the liver, which is is essentially fibrosis of the liver, and that will significantly increase the risk of primary hepatocellular carcinoma. And then also alcohol use, because of the acetaldehyde and the irritation of the lining of the mucosa will increase the risk of estrogen. So I think what I tell people when people ask me, can you drink alcohol? Certainly you can drink alcohol, but daily alcohol is probably not a good idea. Alcohol on special occasions or intermittently is not a problem. Another question that I get asked, or I don't get asked, but I wish they would ask me about it, is the use of ivermectin. So oftentimes I'm seeing a patient, they have advanced colon cancer, or they have advanced pancreatic cancer, and we talk about treatment. They won't ask me, or they won't tell me that they're on ivermectin, or they do tell me they're on ivermectin and they want to know my views on ivermectin. So what is it about ivermectin? So the first question is, what is ivermectin? Ivermectin is actually has been used as an antiparasitic. It's actually used in malaria as well in African countries. So it is a drug that human beings can take, and it's a drug that human beings can take safely. So the safety is not an issue. The big question is, what is it? Is it do anything to cancer? And there's actually a lot of preclinical data on the use on ivermectin in cancer. So there's quite a bit of preclinical data on breast cancer cells, colon cancer cells, prostate cancer cells, brain cancer, bladder cancer, and it actually does have activity in killing off cancer cells. And it does it through mechanisms that have nothing to do with what it does to kill off malaria or parasites. What it does is it inhibits a pathway called PI3K, which is a significant pathway, signal transduction pathway in promoting growth of cancer cells. When we talk about signal transduction in oncology, what we're saying is that a cancer cell gets a signal from outside the cell, a receptor reads that signal, and a signal is passed on to a pathway to do something. And when what happens with cancer is that signal is always on. And so it appears that ivermectin actually can block some of those pathways. It also seems to be able to reduce growth of cancer stem cells. Stem cells are cells that are pluripotent. They can produce skin cells and muscle cells and blood cells. They start as the beginning of all cells. But cancers have stem cells. So cancer stem cells are the beginning cell, and then they produce their progeny, and that goes throughout the body. And it seems that ivermectin can seem to reduce those stem cells, which is interesting. So the data is actually there for ivermectin, for at least the preclinical data is there for inhibiting cancer cell growth. The problem is not the biology of it, it's the pharmacokinetics of it. So what are the problems is you can't actually take enough ivermectin to get to a concentration where it has the inhibitory effect on cancer cells. So when we take ivermectin for malaria or for any parasitic, the level in our body is about 30 to 50 nanograms per milliliter. In order for it to have any anti-cancer effect, it needs 4,400 to 8,800 micrograms per milliliter. And the problem is it's a very lipophilic drug, and so it doesn't stay in the plasma very long. And so it ends up accumulating in places that you don't want the ivermectin to be. And so as a pharmacologic agent for the treatment of cancer, I think it's going to be a difficult drug to show that it can actually treat cancer. There was one phase 1 study in heavily treated breast cancer, and it showed a hint of activity, but it was a small signal. So what I tell people, my patients, I tell them what I know about ivermectin. There are no large controlled studies showing its efficacy. There's definitely a lot of preclinical data. The pharmacokinetics are difficult for ivermectin. I am assured because a lot of my patients do it regardless, and it is a drug that has been studied in human beings for infectious disease purposes, so it's safe there. But I always thought it was interesting about the ivermectin story. So the ivermectin story is complicated that way. It does have data with regards to models for the treatment of cancer. It's pharmacokinetically, it's a difficult drug to use for human beings in actual treatment of cancer. Another question I often get asked is diagnostic imaging, radiology. Women will get mammograms every year. And do mammograms actually cause cancer? Does any radiologic test cause cancer? And just so you know that we're constantly being exposed to radiation in the earth, annually we get about 3.6 millisieverts of radiation a year. So our yearly intake of background radiation is 3.6 millisieverts of radiation. I tell you that because that'll be our baseline of what we're getting with regards to radiation. So does an annual mammogram cause breast cancer? Well, an annual mammogram can give you about 0.4 to 0.6 millisieverts. And so they have looked at models of women, the risk of getting cancer from a mammogram. So there was a study looking at if 100,000 women aged 40 to 74 got their annual mammogram, would it cause breast cancer? And it was an interesting study. And you have to understand these studies. They're very, very conservative. So they're going to err on the side of the model's going to show probably more breast cancers than really could possibly happen, but it's illustrative of the risk of breast cancer. So in this model, this model showed that a yearly mammogram could induce 125 breast cancers, leading to 16 breast cancer deaths. Okay. But if you look at it in relation to screening averts 1,000 breast cancer deaths. So mammography will avert many, 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 many more breast cancer deaths than the radiation effect that it could cause, at least through this model. You could actually mitigate that problem even more. Does every woman need to start her screening at mammogram at age 40? Different bodies start screening at different ages. So starting screening at age 50 further reduces the risk of radiation-induced breast cancers as opposed to starting at age 40. Screening every 2 years for some women may be beneficial as opposed to screening every year. This is obviously something you want to talk to with your physician because different women have different risk levels with regards to breast cancer. So there is a very small risk of breast cancer with radiation. It is very, very small compared to the benefit of mammography. How about CT scanning? Now, when I talk about CT scanning, I'm not talking about CT scanning if you have cancer and it's advanced and you're being followed. The models don't look at that group of people. I'm talking about if you're getting a CT scan for one thing, like you went to the emergency room and you have a belly pain, or you went to the emergency room and you were short of breath. So a CT scan of the chest has 18 millisieverts of radiation. A CT scan of the abdomen has 22 millisieverts of radiation. As just to remind you, a mammogram has zero point 0.4 to 6 millisieverts of radiation. So you're dealing with an imaging modality that does have more radiation. And they looked at a model in 2023. If you do 93 million, that's a lot of CT scans, but we do a lot of CT scans. And you do them, they did 93 million in 2023. What would be the risk in the United States in terms of producing more cancers? And it was actually fairly significant. So 93 million CT scans could potentially produce 100,000 future cancers. Now, I'm not talking 103,000 all at once, but over decades, it could increase the risk of cancers. So, in that group, I think we need to be more thoughtful about who we do CT scans. And so, let me give you a scenario that we want to think long and hard about. If you're a child and you're going to the emergency room, you do want to think about, and they have belly pain, do you want to do a CT scan on every child to rule out appendicitis? Probably you don't want to do that because you don't want to increase that child's risk of cancer in the future. Or do you want, if somebody comes in with a chest discomfort, you want to take a really good history before you decide to order that CT scan and perhaps just order a chest x-ray, or perhaps not order any test and use your good clinical sense about what this is. Is it pneumonia? Is it bronchitis or what? Before you order the CT scan. So that study on looking at a CT scan and increasing like a 5% increase chance of new cancer cases because we're doing CT scanning, we want to think long and hard about that. As opposed to mammography, which I think really is a wonderful screening tool, has a very slight increased risk, but it's the benefits far outweigh any risk. I often get asked about exercise in cancer. Is exercise in cancer, is there a relationship? And actually, there are quite a few studies looking at exercise in cancer. What does exercise itself do? It actually alters the immune system. It actually enhances its effect in terms of tumor surveillance and cancer surveillance. We certainly don't understand why. And a lot of this effect on the immune system really has nothing to do with weight control or weight loss in terms of exercise. But what the studies have shown retrospectively is that those people who do 30 minutes a day, 5 days a week of exercise, there's about a 19% reduction in the risk of colon cancer. There's about a 12 to 15% risk of reduction in breast cancer. Interestingly, there's also a reduction in the risk of gastric and kidney cancer as well. So there's really good evidence that exercise is a good preventative agent for cancer. What was really interesting that got published was something called the Challenge Trial, and it got published last year, and it really made headlines in the American Society of Clinical Oncology. And what it did is it looked at, instead of looking at things retrospectively, which can have some flaws in the study and are not perfect studies, it looked at people prospectively. So it randomized a group of people who had stage 2 and 3 colon cancer to structured exercise. So they got their chemotherapy. So both groups got chemotherapy. And then one group was randomized to structured exercise, and structured exercise was 30 minutes of moderate exercise 5 days a week for 1 year, randomized to another group that did not have structured exercise. And what was interesting in the group that did the structured exercise versus no structured exercise, and you have to realize that both groups got chemotherapy. The group that had structured exercise, their cure rate, their overall survival was 90%, and the group that didn't have structured exercise was 83%. So what was amazing about this was the structured exercise group, they had a chemotherapy effect. That structured exercise was as good as the chemotherapy. Now, I'm not saying we should replace chemotherapy with exercise because the chemotherapy clearly helps. We know that. But adding a structured exercise program also helps. And so whenever I see patients with colon cancer, and I've certainly generalized it to my other patients who have no cancer, they've gotten chemotherapy to prevent their cancer, I've actually asked them to do structured exercise. So we talk about doing 30 minutes, 5 days a week of structured exercise. And for me, structured exercise is walking every day and trying to get your heart rate up. And what do I tell people about their heart rate? I tell them that if they're walking and they can have a conversation, that's probably not the exercise I want them to doing. I want them walking where conversation is difficult. So they're a little bit out of breath because then I know they're getting their heart rate up. So that was actually very exciting, actually. And then they also they did a little bit more of a deep dive in that study, and it actually did show that in that group, there was a prevention of new cancers. There was a significant prevention of new cancers. So it acted as a way of preventing the colon cancer and acted as a way of preventing new cancers. So that was very, very exciting. The next thing I want to talk to, people ask me about diet. And, is there a cancer diet? Now, that's been really difficult to show. No retrospective studies have really been able to definitely show that there is an anti-cancer diet. But I do think that we can look at diets and kind of look at some of the better studies and really the Mediterranean diet, I really would argue is about as good as you're going to get for an anti-cancer diet because it really hits on all the points. It really looks at your proteins, and the proteins that you should be focusing on are fish and lean meats like chicken, and also proteins coming from lentils and chickpeas and beans and nuts. These are all things that are really good proteins that I do think have some anti-neoplastic activity. And also the fruits, fresh fruits and vegetables. In particular, there are certain fruits that I think have more anti-cancer activity than other fruits. So apples are particularly good at reducing the risk of colon cancer. It's actually there's something about the skin of the apple that is shown to have a reduction in the risk of colon cancer. And they had looked at apples and they had shown that you could have about a 15 to 20% reduction in the risk of colon cancer if you were a regular apple eater, which I thought was really significant. Citrus fruits like oranges, grapefruits, lemons, and limes seem to actually have an effect on the reduction in the risk of colon cancer. With regards to breast cancer, blueberries, there was some really interesting studies on blueberries. Blueberries have something called resveratrol, and they also contain phytoestrogens and anthocyanins, which give it that blue hue. They seem to actually reduce the risk of recurrence of breast cancer. And they looked at a study of women who had stages 1 through 3, and they gave them 2 servings of blueberries every week, and it reduced their risk of uh, breast cancer recurrence, which I thought was quite significant. The one thing I will say is what I would avoid are fruit juices. Fruit juices are not helpful with regards to reducing the risk of cancer. It's actually eating the fruit, the fresh fruit itself. With regards to men and prostate cancer, tomatoes seem to have good data with regards to reducing the risk of recurrence of prostate cancer. We think it's the lycopene in the tomatoes. So lycopene seem to have an effect on reducing the risk of prostate cancer. So those are the topics. Those are kind of like a survey of topics I wanted to talk about. I don't want to take away time for questions. If I could quickly just mention something that's topical, it was in the paper recently. One of our previous senators, Ben Sass from Nebraska, unfortunately has metastatic pancreatic cancer, and he was on a clinical trial using what we call our KRAS degraders or KRAS inhibitors. And they really are I think they're going to change the landscape of pancreatic cancer. KRAS is a oncogene that is mutated in pancreatic cancer. In particular, it's KRAS G12D. And there are 2 drugs that are being tested in late stage trials. One of them is daraxonrasib, and the other one is setidegrasib. And they have shown in heavily pretreated patients response rates over a year and survival rates over a year in heavily pretreated patients that otherwise would not really have many options. And that is a huge deal. And so I, as an oncologist who treat pancreatic cancer, am very excited about these drugs and just wanted to let you know that there are hopefully things coming down the pike for pancreatic cancer.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.